Hello everyone, and welcome to our fifth video, which is going to be the beginning of chapter 16. So chapter 16 is going to focus on the types of therapies and treatments we can use for mental disorder. So in terms of approaches to treatment and therapy, the vast majority of people who experience a traumatic event recover from their immediate symptoms and go on to live a normal life. The two greatest allies, the things that have been helpful for us in doing so, are time and the support of friends. Unfortunately, for some people, these two are not going to be enough. So then we have to look at what kind of therapy might be able to help them. Although the title of clinical psychologist, psychiatrist, and even counseling psychologist, they're fairly strictly regulated, the title of psychotherapist is not. So we need to be informed in order to protect ourselves from people who have little training and to help us choose wisely. So this chapter is going to evaluate the two major approaches to treatment, both the biological treatments and the psychotherapies. But today we are going to focus on Module 16.1, which is treating psychological disorders. So at the beginning, we're just going to talk a little bit about how treatments have kind of developed over the years, and we'll talk a bit about how we evaluate treatments. We're not really going to get into any specific treatments in this module. It's more of an overview of kind of what we've established so far in terms of guidelines for treating patients and, the movement from institutions to deinstitutionalization and treating patients where they are. So we will finish module 16.1 in this slideshow, and that will be the content for tomorrow, aka Monday, March 30th's class. So, in terms of therapies, approximately 20% of people are thought to experience a psychological disorder at some point in their lives, even more if you interpret the term disorder more broadly. So when we say 20%, we're talking about, actually meet the criteria for diagnosis for these disorders as outlined by the DSM, but you've got a lot of people who at times are in emotional distress or mental distress who could definitely benefit from help, and if we include those types of people who might not necessarily kind of fit the bill for a specific disorder, that would kind of even increase that number even further. So over the past several decades, attitudes towards therapy have changed. Many celebrities have opened up about their struggles with mental illness and trauma, and self-help books line bookstore shelves. So everywhere you go, especially if you go to kind of a big chain bookstore, you're going to see a self-help / psychology section with a whole bunch of books telling you how you can improve your life in a whole bunch of ways. So each year, approximately 10% of Canadians seek some form of treatment for mental health issues, although not all groups are as likely as others to seek treatment. So, for example, we see far more women than men seeking treatment. We tend to see a lot of people between the age of 35 to 55 compared to people who are younger or older than that range. And we tend to see Caucasian people seeking treatment more often than members of other ethnicities. Unfortunately, there are many barriers to treatment that exist, so we're going to outline and talk about a few of those now and maybe how we can help reduce some of those barriers. So in terms of our barriers to psychological treatment, in one study of 1,600 adults who have been diagnosed with depression or an anxiety disorder, only 30% were receiving some form of therapy. So basically, what you're seeing is only 1 in every 3 people who has been diagnosed with one of those mood or anxiety disorders are actually receiving therapeutic treatment. Even when people do seek therapy, about half of them significantly delay doing so after becoming aware of their mental health issues. So they try to hold out as long as they can before admitting that they need help. And so a question we might ask is, why might people choose not to seek help? You would think, in terms of if somebody broke their arm or cut their hand, they're going to go to a hospital right away and seek treatment. But with mental health issues, it's not that simple. So there are many reasons that we're going to discuss here about why people may either choose not to or not be able to access the psychological treatment that they need. One common problem is that disorders themselves are inherently ambiguous. So I mentioned this when we talked about the DSM in the last chapter, but there's a very fine line between mentally healthy and mentally unhealthy, and there isn't really any kind of objective way of measuring, when you kind of cross that line. So a lot of the time it's hard to really be able to see if you kind of fit the bill for that diagnosis or have those criteria that people would instantly go, okay, I need help. Also, unfortunately, people are often very motivated to not see themselves as mentally ill. Nobody wants to think that they're ill and need help. And so unfortunately, a lot of people can kind of live in denial from that, and they're not seeking the treatment that they need to become healthy. Other people may be unwilling to risk the social stigma or are skeptical of the efficacy and safety of different treatments. So there have been studies that have shown that 99% of people say that they would seek help if they believed it would be helpful for them. So clearly, a large reason why people aren't seeking psychological treatment is that they don't necessarily believe that it would benefit them. So we'll talk a bit more about the social stigma and kind of talk a bit more in detail about some of these barriers. So as mentioned, one common barrier to psychological treatment is the stigma toward mental illness and the process of therapy itself. Imagine how different it might be if a business person tried to take time off work for a surgery versus to deal with his emotional issues. So unfortunately, again, if you have surgery or if you have a physical illness that you need to take care of, people are very understanding. They're often, unfortunately, not as understanding when it comes to issues surrounding mental illness. Unfortunately, in many professions, mental illness carries a strong stigma that could result in workplace harassment or discrimination. There may also be social costs. This is some kind of very sad statistics here, but 1 out of 2 Canadians admit that they would likely not socialize with a friend who had a severe mental illness. And 1 in 4 Canadians admit that they are afraid to be around people with serious mental illnesses. So that's a lot. 50% of Canadians and 25% of Canadians not wanting to socialize with someone with severe mental illness or admitting that they are afraid of those people. So we can really see that there's a lot of stigma there. Also, in terms of gender roles, in many countries with strong gender norms, such as the US and Canada, there are extra pressures on men to avoid treatment. So going to therapy and needing help are incompatible with the idea of strength and independence, which is kind of part of that gender role of a male in our society. This at times may lead men to deny that they have any problems or to believe that they just need to get over it. This view does not promote talking about emotions and acknowledging vulnerabilities, which would help these men to heal and recover. So when what they really need is to talk to somebody and work through their issues, they're kind of running in the other direction because of that stigma and because of the fact that it doesn't quite fit that gender role in our society. In fact, getting men to see therapy differently has been such a challenge that the National Institute of Mental Health has staged public awareness campaigns in the US, such as one called Real Men, Real Depression. And luckily, there has been some initial evidence showing that these types of programs do have some success in helping men kind of come forward and admit that they need help and be more accepting of treatment for psychological disorder. So a little bit of good news there, but we still have a long way to go. In terms of logistical barriers, 2 of the greatest barriers to mental health treatment are about access, whether people either have the money or the time for treatment. And so unfortunately, therapy is associated with both direct costs. A session with a clinical psychologist can run upwards of $100 an hour. So there's definitely direct costs there, as well as numerous indirect costs. So if you are somebody who needs to see a therapist, you might have to take time off work, you might have to worry about transportation, you might even have to worry about who's going to take care of your kid while you're at your appointment. Unfortunately, government healthcare coverage in Canada generally only includes psychiatrists. So psychiatrists are actual medical doctors. They're covered kind of by our general government healthcare system, but when it comes to accessing people like clinical psychologists, counseling psychologists, and other therapists, sometimes those people, your insurance companies or the government won't necessarily cover your appointments with them, and that leaves other therapists less able to reach people who can't afford their services. So without easy access to counselors, people often try to cope with life as best they can until problems develop into major issues that they can't ignore. So unfortunately, at times this leads to people kind of putting it off until it becomes such a big issue that they end up, in the emergency room or hospitalized because they just let it kind of go too far. With one kind of bright note to point out here, some community health centers operate on what they call a sliding scale for rates, which is kind of cool. It's a model basically based on the income of the patient, so they only kind of pay what they can afford. So that's put into place in some community health centers and things like that, but still it's not enough to be serving the needs of all of the Canadians that need help. Now we're going to talk briefly about involuntary treatment, as this is something that it does still happen quite often. Sometimes people, if they're unwilling to admit that they have a problem, or if they are exhibiting behaviors that are dangerous to others, they will be required to enter mental health treatment against their will. So some people can be compelled through courts or through social service agencies, or even doctors. Basically, involuntary treatment means that they have been required, which really means forced, to enter mental health treatment. The majority of these cases arise due to highly erratic or disturbing behavior in which the person may pose a risk to self or others. So typically you're not going to be able to kind of get someone committed, we'll say, to a mental health treatment or a mental health treatment center without some proof that they really are a risk to themselves or others. This outpatient commitment is a highly contentious issue because in essence it strips people of some of their basic rights. So what you're doing is you're telling them that they have no choice, they have to engage in this therapeutic setting, which may be something that they really aren't comfortable doing or don't want to do. And another issue with it potentially is that it may easily be misapplied. So unfortunately, at times, you see a disproportionate amount of people from certain ethnic groups or low socioeconomic status who are being kind of forced into treatment relative to other groups in society. So far, research on the issue has failed to resolve the controversy, whether or not involuntary treatment should continue to kind of be a thing. Some studies show that a significant number of patients benefit from mandated treatment, but on the other hand, many people placed in involuntary treatment feel coerced and resentful, and not everyone benefits. So sometimes involuntary treatment may be done from a more kind of benevolent point of view. So sometimes people really think that they're helping, poorer people or people who wouldn't necessarily be able to afford treatment by getting them committed to involuntary treatment. But of course, there are also some undesirable reasons as well, such as kind of what I mentioned before, prejudice and things like that. So it seems like there are kind of some pros and cons, and the jury is still really out on this one, whether or not it's something that is a good thing and we should continue with. Now we'll talk a bit about the different types of mental health providers. So far we've kind of talked a bit about some of the barriers to treatment. Now we'll talk about some of the professionals that engage in psychological therapy and psychological treatments. So the terms psychologist and psychiatrist are often incorrectly used as if they mean the same thing. There are actually very major differences between the two. I kind of alluded to this a little while ago, but psychiatrists are actually medical doctors, whereas clinical psychologists have obtained PhDs or PsyDs, so doctorates in the philosophy of clinical psychology or doctorates in psychology itself, and are able to formally diagnose and treat mental health issues ranging from the everyday and mild to the chronic and severe. So compared to a psychiatrist, they're not a medical doctor, they're not able to prescribe medication, but other than that, they can do pretty much everything a psychiatrist will be able to do. Then we have counseling psychologists, who are mental health professionals who typically work with people who need help in more common problems, such as stress and coping, issues concerning identity, sexuality, and relationships, so family therapy, marriage therapy, that type of thing. Anxiety and depression, so kind of some of the less severe mental disorders, and developmental issues such as childhood trauma. So they may either have a master's or a PhD degree. I'd say the majority of counseling psychologists that you see have a master's degree, so they tend to deal with slightly less severe issues than a clinical psychologist would. Practitioners of both clinical and counseling psychology work in many different capacities and settings. So some may focus on individual therapy while others focus on group therapy. Some work in offices and private practice, others work in hospitals or kind of with another organization. So there's a lot of different settings and different capacities that clinical and counseling psychologists can work in. There are other people with various levels of training and backgrounds who also conduct therapy. So for example, clinical social workers and psychiatric nurses. And then finally, psychiatrists, on the other hand, are actual medical doctors. They've gone through medical school, who specialize in mental health and who are allowed to diagnose and treat mental disorders through prescribing medications. So they are able to use medication as a treatment. However, many still work from a biopsychosocial perspective, so they're not only focusing on the biological and the kind of the more medical side, but also focusing on social and psychological aspects as well. And so many psychiatrists will also engage in kind of what we call talk therapy at times as well. Typically, in the US and Canada, clinical psychologists cannot prescribe medication. However, there are several states. This is something that I looked into recently because clinical psychology is what I'm going into. There are several states who have allowed their clinical psychologists to prescribe medication, and there are kind of pros and cons to that. We won't get into them here. But kind of one thing to keep in mind is many times clinical psychologists and psychiatrists will often work together. So the psychiatrist can kind of prescribe medication and kind of monitor the more medical aspects, where the psychologist can kind of engage in the talk therapy, and they can kind of work together to help treat patients at times. Now we'll talk a little bit about inpatient treatment and deinstitutionalization. So I mentioned the term deinstitutionalization in chapter 15 as well. But as we mentioned in the last chapter, history has not always been kind to those with mental illness, especially those suffering from more severe disorders. And I want to point out, because I mentioned when I mentioned depression and anxiety a second ago as something that counseling psychologists often work with, I said less severe and more severe. It doesn't necessarily mean severe in terms of, you know, the actual disorder itself and how badly it's making you feel. What I'm talking about when I talk about severity of disorders is more disorders that are a lot kind of harder to treat, may have a lot of issues in terms of diagnosis, and maybe exhibiting some of the more kind of psychotic symptoms and things like that are a little bit harder to deal with at times. I'm not making light of any disorder. Depression can be just as debilitating to somebody as schizophrenia, but when I talk about severe, I'm typically talking about kind of the psychotic disorders like schizophrenia and things like that. So these people were often separated from society or confined to what we kind of called asylums. Unfortunately, typically in these facilities, the focus was not on treating the patients, but on protecting society from these individuals, which was an awful way to look at things, but unfortunately, that was the way it was. So unfortunately, many mental institutions in the past were terrible places for their patients. They were sometimes subjected to brutal confinement and torture, and a lot of the time they were living in kind of what we would consider inhumane conditions. So luckily, by the end of the 19th century, psychology was gaining credibility as a science, and the asylums or institutions began to focus on treatment and providing their patients with better living conditions. So eventually, I guess it was pointed out just how awful these settings were for the patients, and as people began to treat psychology more seriously, they were able to advocate for the more humane treatment of these patients. Unfortunately, these asylums and institutions were often still overcrowded, but the conditions were a lot better than they were in the early days in the earlier asylums. So in the 1960s, effective treatments began to be developed for some disorders, and there was a society-wide movement towards what we call deinstitutionalization. I'm pretty sure this is the same definition I gave you in the last chapter, but just to recap, deinstitutionalization refers to the movement of large numbers of psychiatric inpatients from their care facilities back into regular society. So we saw over the next 3 decades an 85% decrease in the numbers of inpatients in psychiatric institutions. So in the decades since, mental health care providers have compiled many resources and strategies to help people in distress, and now inpatient treatment is geared towards protecting the individual patient from harm while encouraging a quick and successful return to regular society. So fortunately now we're no longer focusing on institutionalizing people to keep them away from society and keep society safe from them. We are focusing on helping the individual patient and improving their outcomes. In the place of asylums, patients requiring long-term care now live in residential treatment centers, which are housing facilities in which residents receive psychological therapy and life skills training so that they're able to reintegrate into society. So these treatment centers are going to vary in terms of their kind of level of security. You're going to have kind of low security treatment centers in which people can kind of come and go as they please. It's more like a kind of a place to stay while they engage in treatment, whereas you're going to have, medium to high levels of security in some treatment centers, and those are probably going to be the ones that are dealing with patients who are at risk for being, violent, harming themselves or others. So in some of these treatment centers, you're going to have locked doors and the inability to just come and go as they please. Now we'll talk briefly about community psychology. So we do have some psychologists who wish to place less of an emphasis on one-on-one therapy and focus more on working with the community at large. So community psychology is a field which focuses on identifying how individuals' mental health is influenced by the community in which they live, and it emphasizes community-level variables such as social programs, support networks, and community resource centers to help those with mental illness adjust to the challenges of everyday life. So community psychologists are more focusing on helping set up programs and networks and resource centers that are going to be available to the community at large, rather than focusing on kind of individual one-on-one therapy. So through working at a community level, these psychologists hope to prevent or minimize the development of disorders, enhance factors that help strengthen people, and help make people more resilient to the kinds of stresses that may undermine their mental health. So community psychologists are more geared towards the prevention a lot of the time of disorders themselves rather than the treatment of these disorders. So now we have to talk a little bit about evaluating treatments. So we just talked about the fact there are a lot of different types of treatments and different types of practitioners, different types of settings. So given the diversity of these approaches and settings, it's important for us to know which approaches are going to be effective, not only for the therapist's sake, but also so that we're able to provide patients with the best care that we possibly can. So in the mid-1990s, the American Psychological Association set up task forces to evaluate different therapy practices, which led to a call for more studies to examine the effectiveness of different therapeutic approaches. So basically, we're trying to ensure that evidence-based treatments can be identified. So if we're talking about evidence-based or empirically supported treatments, they are treatments that have been tested and evaluated, and of course, as we've learned from, last semester when we did the chapter on research methods, the most rigorous way of testing anything is through an experiment. Unfortunately, it is nearly impossible to conduct a true experiment when we're evaluating therapies for a variety of reasons. So we're going to talk a little bit about why it's not as easy as you might think to kind of ensure that treatments are empirically supported and evidence-based. So one major issue is that it is unethical to place people into a control group that receives no treatment of any kind. So that's a really big issue when you think of the fact that in a true experiment, you need to randomly separate half of your participants into a control group, which receives none of the independent variable, and then the other half into your experimental group, which receives the manipulation independent variable. But unfortunately, you can't just randomly assign half of the participants because all your participants are going to be patients who are obviously dealing with some kind of mental disorder. You can't just randomly assign half of them to not get any treatment. That would be unethical, to deny them the treatment that they would need. Another major issue is that it is also generally impossible to use a double-blind procedure. So one of the best ways to help eliminate bias in experimental research is to use a double-blind procedure in which neither the participants or the experimenter knows which group is which. But obviously a therapist is going to know which kind of treatment they're administering. So they're going to know whether or not their patient is in the control group or the experimental group. There are also issues in that therapists differ widely in terms of their own level of relevant skills, and much of the effectiveness of therapy comes from what we call the therapeutic alliance, which is the relationship that emerges through therapy. Therapists who are more socially skilled, and by that we mean they exhibit more warmth, concern, and empathy, and clients who are more open to the process and willing to trust tend to have more success in general. So it may not necessarily be due so much to the type of treatment as it is to the skills of the therapist and kind of the attitudes of the client or the patient. So as a result, it is very difficult to adequately test the effectiveness of approaches. And now we get to a part that I kind of added in from the old text. So again, don't focus on this in terms of testing. I just think it's kind of important to talk about. So when we're talking about evaluating therapies, one of the major things that we focus on is something called the scientist-practitioner gap. And this first point here is kind of just another point talking about therapeutic alliance. Culture can definitely play a role in whether a therapeutic alliance is formed. So cultural differences and syndromes. So the fact that some disorders are going to look very different from culture to culture, and cultural distrust, which unfortunately kind of occurs at times when there's a mismatch between the culture of the therapist and the culture of the client, can at times keep therapists and their clients from connecting if there is not a therapist-client match. So that's another reason that it can be hard to kind of really judge therapy and whether it's the actual type of therapy that's working rather than kind of more interpersonal issues about the therapeutic relationship. So there's also the issue of, again, what we call the scientist-practitioner gap, which basically it refers to the fact that many psychotherapists believe that it's not possible to evaluate psychotherapy, that we shouldn't even be trying to evaluate psychotherapy using standard empirical methods because there's no way it's possible for us to capture the complexity of the exchange between client and therapist. But unfortunately, that leads us to question, how then can we validate and assess the reliability of these therapies? So psychological scientists, on the other hand, they agree that therapy is a complex process, but see no reason why it cannot be scientifically investigated like any other complex process. So basically, there is a whole other debate, which is kind of outside of the issues we just mentioned about how hard it is to empirically evaluate treatments. There's also this big gap between practitioners and scientists, in which the practitioners often say that we shouldn't even be trying to empirically evaluate these therapies. Over the years, the breach between scientists and therapists has unfortunately widened. One reason may be the rise of professional schools that are not connected to academic psychology departments. So there are a lot of programs that you can do online and other sources that train you to be a therapist of some sort, but they're not necessarily kind of connected with an actual academic psychology department that's backed by kind of empirical research evidence and things like that. Another cause may be the proliferation of new therapies trying to gain a foothold, some of which are packaged and promoted without any scientific support at all. I'm not really going to get into this, but things like neurolinguistic programming and eye movement desensitization and reprocessing, or EMDR therapy, both really have no empirical support comparative to other approaches that we've used. So it's recently been reported that the current state of clinical psychology is comparable to that of medicine in the early 1900s. Personal experience is typically valued over scientific research, and luckily we do have kind of one promising strategy in terms of the new accreditation system. So if you are looking to go into clinical psychology, a PhD, a PsyD, or in a lot of the kind of master's and PhD programs in counseling, you're going to want to look for programs that have been accredited, which means that they have been kind of given the go-ahead by an accrediting agency such as a psychological association to say this is actually training quality mental health professionals. So that is one thing that's kind of helping us out with some of these issues. So the final thing we're going to talk about in this module is, can self-help treatments be effective? Many people attempt to address their psychological problems by using resources that don't involve visiting an actual therapist, such as through the use of self-help books. Unfortunately, there are so many of these books, and they're written by people with a variety of different credentials, or lack thereof. Some people who are clinical psychologists with 30 years of experience write self-help books, but you also might have one from Joe down the road who just had some ideas about what could help with mental health and decided he was going to write a book about it. And what we see a lot of the time as a result of that, and as a result of the fact that a lot of therapists and clinicians don't necessarily agree on techniques, is that these books are often disagreeing with each other as well. So the question then is, which approach is right? How can we know whether this literature is effective? And that's a very, very tricky issue. There has been some research on bibliotherapy, which is the use of self-help books and other reading material as a form of therapy, but it has had mixed results. So for example, we had one study of 170 elderly primary care patients who were diagnosed with depression, and basically they divided them into two groups. One was given, well, both were given standard care procedures, and then one of the groups was given kind of a self-help book to read. And in that case, they saw that there didn't really appear to be any change in the symptoms of the depression, whereas there have been meta-analyses on a book called Feeling Good, which is supposed to help patients who suffer from depression, and that one has been shown to seemingly reduce depressive symptoms. So it really seems like it depends on the book, depends on the patients. It's something that's not really easy to, again, not really easy to assess empirically. The biggest strength of self-help literature is also its biggest weakness. There are so many books available that it is impossible to ensure that they are all credible. People planning on using self-help books should ensure that the authors have the necessary qualifications to advise people about mental health issues. So if you do want to use a self-help book, look for someone with at least a master's in counseling, something like that, preferably, a PhD or a PsyD or an MD. You want people who actually have qualifications to be giving you psychological advice. The main reason that caution is necessary when using self-help books is that many psychological disorders are both complex and emotionally intense. So we have to keep in mind that these books do not always prepare people for the emotions that can arise as they confront the symptoms of their disorders. So a lot of the time, once you start bringing those things to the surface and trying to kind of evaluate them and treat them, if you're doing that at home alone, or even if you're doing it in therapy, a lot of the time some really strong emotions can kind of come along with that. And so unfortunately, if you're experiencing kind of those emotions and kind of maybe kind of almost a resurgence of some of the negative symptoms of your disorder through using self-help literature, if you don't have a professional there to help you, that can lead to very detrimental outcomes. So self-help options do have some great advantages in terms of cost and availability, but research does suggest that they are less likely to lead to significant change. So in-person therapy does seem to lead to more kind of significant or consequential change in terms of helping people reduce the symptoms of their disorders and cope with their disorders. So in conclusion, if you are experiencing psychological distress, it is probably advisable to speak to a mental health professional at least once. Even if you go and see them and you don't find it helpful, and you would rather, stay at home, read self-help books, or engage in some other form of therapy online or what have you, at least then, if you see a mental health professional at least once, they may even be able to suggest some good resources for you. So definitely, self-help books can help at times, but we do have to be very cautious in terms of our use of them. So that is the end of this module. If you have any questions, we're going to have our chat tomorrow morning during class time, so make sure to pop on and ask. This will be our material for Monday, March 30th. And then hopefully within the next day or two, I'll get the other two modules up, and that will be the rest of the content for our course. So once I post module 2 and 3, that will be all the content that we'll cover on your final exam. So you only have 2 weeks worth of content. I'm looking at this slideshow. It's coming in at like 32 minutes for our 50-minute class tomorrow, and the other 2 modules should be about the same, maybe even a little less at times. So we'll definitely finish with time to spare. So I will see you soon, or talk to you soon at least.